I'm just going to get started, starting from like a review, just from my slides, highlighting things as we're going forward. Hopefully going this way will help reinforce things and kind of make things relevant now that you've gone through the entire course. Yeah. Better? I don't know if the music's okay. This looks like garbage. Let's do that. Okay, let's go through this fast. So F waves and flutter. Let me go back. So for the most part, it's going to be a sawtooth. Let me just change that to a real pen. And then a normal QRS. So 1, 2, 3, and then it's a QRS. And this is 1, 2, 3. That's basically, but you'll see is either it could be like 2-to-1, it could be 3-to-1, 4-to-1 conduction. The big thing with atrial flutter and atrial fib is really the rate control of the QRSs. The atrium's going to go crazy anyway, but those QRSs, you want to make sure that their rates are controlled. So obviously, if they're 2-to-1, they're going to have a very, very fast heart rate. If it's 3-to-1, 4-to-1, heart rate goes down because it's going to take a little bit before that AV node will send a signal through. Okay, let's go through some stuff here. A couple things about paper. Make sure you know time going that way, millivolts going up. What's the printer speed of the paper? Tells you right there, 25 millimeters per second. Make sure you know those things. Obviously, we all know by now, P wave is atrial, QRS ventricular, T wave is your ventricular repolarization. Your isoelectric waveforms, these are things that are just going to be baseline. They don't have any bumps or depressions. PR segment, just AV node delay. Your ST segment, again, these are isoelectric because if you look there and from there to there, let me get rid of the other one. Those are going to be flattened baseline. They don't deviate up and down. And the TP interval, we don't really look at very much. By now, hopefully this should look pretty familiar. There's no cardiac testing on the exam, so don't worry about it. You'll get it in cardio as more just an introductory thing to make sure that you knew what it was for Dr. Ovai's class. But there's no questions on advanced cardiac testing on your test tomorrow. There's our graph paper. Again, 0.04 seconds is one little box. 0.2 seconds is one big box. So 5 big boxes is 1 second of time. P wave, atrial depolarization contraction. SA node fires, usually round and upright. Best seen lead 2 and V1. PR segment, just between the end of the P wave and the beginning of the QRS complex. PR interval is what we're really looking at. So make sure you know PR interval normal duration is 0.12 to 0.2 seconds, or 3 to 5 small boxes. So if you're looking at this one, you just shade in the areas of when you see it. And we can 1, 2, 3, 4, 5. It's still going. We know we have first degree AV block here. It's going to be a mix. You're going to have just straight up 12 lead EKG, and that's to say, what is the rhythm? What is the MI? Or you'll have strips as well, just plain rhythm strip, and it'll just say, what's the rhythm? Those are going to be your blocks, your atrial and ventricular arrhythmias as well. QRS complex, 0.08 to 0.12 seconds, 2 to 3 small boxes. Scarbosa's criteria, let me go to that one. Okay, that's fine. When you guys were asking before about STEMI mimics, Scarbosa criteria, but also make sure you know pericarditis, Brugada syndrome. Those are the ones, they'll be here. Remember RV infarcts, you do that whole V1R, move it over, or V4R, you move V4 over, this way. Pull it over this way, and you look at the right ventricle. Actually, I got some right here. Let's do some right now. Okay. Hope you didn't see those so fast. Okay, so just type in chat what you think this one is, and we'll go from there. It's an MI, because this is the MI lecture. I don't even know if we can do this. I don't know, the delay might be too much, but we'll keep it. It's anteroseptal. All that, all that. Hang on. Okay, let's probably this one. Okay, Brugada syndrome. Key things about Brugada syndrome. ST elevated, V1 and V2 are the big culprits. So you're going to see something that looks like that. V1 through V2 is where you're going to see Brugada syndrome. Okay, so that's really all you got to know for that. ST elevations, V1, V2, they have a very, very unique shape to them. So that is Brugada. Let me find. So type 1, again, that coved ST segment. This arc shape is a coved shape, and that's, again, this is the shape that you see with Brugada syndrome. Okay, pericarditis, make sure you know pericarditis. Big thing with pericarditis. All the leads are going to show ST elevation. And that's what you get with pericarditis. So you see elevation all over the place. These leads, that lead, these leads, these leads. These are all different territories, but they're all showing ST elevation. They're also going to have certain complaints. Leaning forward helps. Same thing we went over in pericarditis with ClinPath. Okay, so if you have a patient coming in complaining of chest pain, that they feel better if they lean forward, stuff like that. Then you see with ST elevation across all leads, it's going to be pericarditis. Let me find the Scarbosa's criteria. Should have been here. Okay, all I want you to know for Scarbosa's criteria is why you would use it. So don't go crazy trying to memorize all that Scarbosa stuff. Where do I have it? Oh, I'll pull up their chart. Hang on. Okay. So there's more up here. Okay. So Scarbosa's criteria, why would you want to use it? Because when you have acute myocardial infarction, okay, you're going to see ST elevation. That's what you normally want to see. However, if they also have a left bundle branch block or they have a paced rhythm, it's going to alter the way the QRS complex looks. So it's hard to diagnose someone as having an MI if they already have an underlying baseline of ST elevation. So the Scarbosa's criteria comes into play when you're trying to evaluate a MI when they have an underlying left bundle branch block. Okay, that's the basic of it for right now. Just know that for now. I'm not going to have you diagnose and calculate all that stuff. Just know what would you use it for? What's its purpose? Okay, so that's where that goes. I'll just keep going. Pull up this lecture. This has a lot of rhythms. Okay. This is a good one. See you guys tomorrow. Okay. So, ECG analysis. Everything you do the first time you see an EKG, whether it's a rhythm strip or a 12 lead, first thing is look at the rate. What's the rate? Okay, there's many different ways to do it. Then we look at the regularity. Are the P waves marching out regularly? Are the QRS complexes marching out regularly as you go across from this one to this one to this one to this one? They should be regular and even. Remember the cardiac cycle. We went over that many times in physio and pathophys. You got 1 second to get everything done in a 60 beats per minute heart rate. So you should have regularity between the P waves, if you march out every P wave, and regularity between every single QRS complex. So we look at that. And then we look at the P waves. What are the P waves doing? Do they look the same? If they don't look the same, then you have that wandering atrial pacemaker because they're coming from different areas. How do they look? Are they peaked? Peaked P waves that is your right atrial enlargement. And if the P wave looks like that, like an M, there's your left atrial enlargement. So look at the P waves. Okay, are they regular? Is there a P wave before every QRS interval, a QRS duration complex? Okay, look at the PR interval. Measure it out. Is the PR interval within 3 to 5 small boxes? Yes, it is. Okay, that helps with one of your differentials. Is it not? It's not. It's wide. Okay, so we have an extended PR interval. Is it just first degree heart block or something else going on? You do not need to do anything about those fascicular heart blocks. Don't worry about the fascicular heart blocks or the posterior blocks. That's more for electrophysiology, tertiary care for these patients. Don't worry about those fascicular blocks. The bundles for sure. Right bundle, left bundle, make sure you know what those are. But the fascicular blocks, don't worry about. So PR interval, if it's lengthening, Is it lengthen, drop? There's your type 1. Are the PR intervals constant, but randomly you drop a QRS complex? Well, then you have your type 2. QRS duration. Why is that important? Because if the QRS is narrow, we know it's an atrial issue. If the QRS is wide, it's a ventricular problem because of all where the impulse is generating from. Wide QRSs, they start in the ventricles, whether it's bundle of His, but it is in the ventricle. And if they're narrow, it starts above. Heart rate, there's many different ways to do it. Make sure you know the different types. You can count them out. 6-second method is the best one. You just, how many complexes are there in 6 seconds? Multiply by 10, there's your answer. There's another one, count total seconds between 2 ROAs, divided by 100. That gets a little confusing. Regularity, we talked about that before. Again, is it occasionally irregular? That's your sinus arrhythmia. Regularly irregular, that's also, that sinus arrhythmia can do that as well. Irregular is AFib. This can also be a flutter as well. Again, P waves, how are they looking? Complex, wide, whatever. I'll get to the left and right bundle branches very, very soon, Maniba, I won't forget. I just wanted to finish this part. So when you're looking at an EKG, these are all the different things it could be. Every single rhythm that you've learned about is only going to have one combination of these things. If everything is regular, the only thing it could be is normal sinus rhythm. Is everything is regular, but the heart rate is 100, sinus tach. If everything is great, but we have an irregular rhythm, then you get into your AFibs and so forth. Strips in the test be 6 seconds? Yes, they're going to be 6 seconds. Or if it's not, it'll be very, very obvious what I'm looking at and what I want you to know for that one. Okay, let me go to the bundle branches. Okay, so let me draw this out. Okay. 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 So, is that yellow showing up okay? So we have our conduction system. In a left bundle branch block. Okay, so in this case, we have a block right here, let's say. Because of that, the impulse cannot get through that left bundle branch. We have a block there. It could be fibrosis or scarring. We talk about that a lot in ClinPath. The fibrosis and scarring messes up your electrical conduction. And in these intraventricular conduction delays, one of the most common things that you'll see. So as the impulse is coming down, it gets stuck here. So what has to happen is, sorry, this is going crazy. The impulse as it's coming down, let me change it to orange. So its impulse is coming down. It gets stuck there. What has to happen, the right bundle is going to depolarize that area first. Then the impulse, as it comes down this way, it's going to spread to the left side because of the left bundle. That's why at first the impulse and why you have the bunny ears is because it goes this way first, then that way, and then finally that way. If I turn this, if I spin it, I don't want to screw it up. But if you spin it on its side, you see an up, a down, and an up. And that gives you your RSR pattern. Now, where do you see this? If you see the bunny ears, the RSR prime pattern, bunny ears, mountains, whatever you want to call them. If you see it in V1, V2, it's a right bundle branch block because the right side is going to depolarize first, giving you a positive complex in V1, V2. Normally, the left side's pulling all the electricity, but we have a block on the left bundle. So it's got to go to the right side first. Once it gets past the block, then it comes back over. So Maniba, I hope that answers. And then the opposite is just true with a right bundle. It's mainly going to be on the left side, and at the very end, it'll peak over. And that's why you'll see that pattern, again, RSR prime, V5 and V6 as your left bundle branch blocks. Okay, so hopefully, Maniba, I hope that answers your question about the bundles. Okay, so right ventricular infarcts. What artery if we have an infarct right there? Inferior infarct. So with an inferior infarct, what is the major artery that feeds the inferior part of the wall? Right coronary artery coming off the aorta feeds the inferior wall of the left ventricle. But it also feeds the right ventricle as well. The right ventricle is right there. RCA is right coronary artery. Remember, we have the right coronary artery and you have your left coronary artery that come off the aorta. Aortic roots. So the right coronary artery also feeds the right ventricle. So if you have an inferior wall MI, inferior wall myocardial infarction, you also have to worry about the right ventricle having an infarct. And the way that you do that, you take V4 off and you put it in the same V4 spot, but on the right side of the chest. And if you start seeing ST elevations here, we know we have a right ventricular infarct as well because we're having elevation. If we see ST depression on those for that right V4, then we know we have ischemia in that vessel. So that is the relationship between right ventricular infarcts and inferior wall MI. But remember, it's all about blood supply. So you make sure you know the territories, know blood supplies. You know, if I told you you have your circumflex is on the opposite end, it's going to be your free wall is your circumflex. If I say you have a lateral MI, what vessel is feeding it? It's your circumflex. So the anatomy comes in also. Okay. I think I have strips at the end of this. Okay, so here is a flutter. Let me go to this. Okay, 1, 2, 3, but it's variable, Hannah. 1, 2, 3, 1, 2, 3. This is only one there, only one there. 1, 2, 3, but it alternates between 1, 2, 3, and 1. So this will be considered a flutter with 3 to 1 conduction or 1 to 3 conduction. For every 3 P waves, there is a QRS complex. So what I was saying before was these are the only things it can be. So sinus bradycardia is going to have a low heart rate, regular rhythm. P wave is going to be normal before every single beat. PR interval is normal. QRS is normal. Sinus bradycardia. That is the only combination you can have with all these things and be bradycardia. That's it. So if you want to you can make one big table. Be like, this is you can do heart rate, rhythm, P wave going across, and then you have your diagnoses going down, and be like, okay, which one has this type of rhythm? Sinus tach. The only change is the heart rate. Everything else, normal, 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 normal. Sinus arrhythmia. Heart rate's normal. What's the issue? Irregular rhythm. Why? From breathing in and out, you slow down your heart rate or it picks up again. That's a normal finding. In a few weeks, you guys will be doing EKGs on each other. I'm sure you will find that. You'll see sinus arrhythmia. It's normal finding. It's okay. So that's really it as far as the SA node is concerned. The things can happen. Now we start getting some issues with some firing going on with atrial sending off other signals. Any premature atrial complex, what you want to do is look at the P wave. It's going to be a different P wave, an abnormal, non-sinus P wave. Why? It's coming from a different area. So it's going to look different. But the QRS, the T wave is all going to be normal. Sure, let's jump over to that one. Okay, a couple of things. Make sure you know this one. This is all you got to know as far as axis. Thumb up, thumb down. Which one do you fall into? That's all you got to know. Don't worry about degrees and all that stuff. Do your thumbs. Make sure you know the causes of every deviation as well. What causes an extreme right axis? What causes right axis deviation? I know that's on your slides. He went over that. What causes left axis and so forth. Okay. Left atrial enlargement. There's two things that you can see with left atrial enlargement. The main one is this P mitral. Let me just start this up. Okay. P mitral or an M look. If you see this, it's because, remember, when you have a P wave, this first initial bump is the right atria. Left atria. If you see the very, very tall right off the bat, that means the right atria is enlarged. It's using up a lot of electricity. It's going to show a big peak. In this case, the right side is normal, but the left is now bigger, so you have a bump again. So in lead 2, we get a notched P wave or P mitral or the M shape. V1, because of V1 is now perpendicular to the impulse, you see biphasic. So if you see a biphasic P wave in V1 or P mitral M in M for the P wave in lead 2, left atrial enlargement. So in a 12 lead, you're just going to be looking at EKGs, but what's the best lead to look at? Look at that. Lead 2. Let's look at V1. What does V1 show? That biphasic P wave. So in this case, we know it's left atrial enlargement. R wave progression. Here's the right atrial. Here, right atrial enlargement. Lead 2, peaked P wave greater than 2.5, or lead V1, V2 greater than 1.5. Again, we're going to have peaked P waves for right atrial enlargement, M for left atrial enlargement. So R wave progression, as you're moving across the precordium from V1 through V6, you should see what's called normal R wave progression as the peak of these R waves reaches a peak around V5, V6. If you see poor R wave progression like that, that means there was an injury, or you'll see that usually after a myocardial infarction, you'll lose that progression. But this is a normal finding. You want to see that progression. So right ventricular hypertrophy. Remember your precordial leads. And so on this case, this is the right side of your heart. These are the left side of your heart. So V1, V2, just get that in your head. V1, V2 is the right side. That's why with right bundle branch blocks, you see it here. Left is over here. Right ventricular hypertrophy, you see on V1, V2. Left ventricular hypertrophy, you see in V5 and V6. These are the closest leads to that part of the heart. So if we have right ventricular hypertrophy, we're going to see very, very, very tall R waves in V1, V2 because the right ventricle is pulling so much electricity. You also see right axis deviation with these patients. But again, very tall R wave. So that whole R wave progression is thrown out the window now because of the right ventricle being so large. We've lost our R wave progression. Here is another one. Okay, very, very tall peaked QRS complexes, these tall R waves in V1, V2, right ventricle hypertrophy. This is the right side of the heart. Look at the left side, they're normal. Left ventricular hypertrophy, now you're going to see the opposite. Very, very, very tall R waves in 5 and V6. Okay, so same reason. These are going to be very deep because now they're getting the opposite effect. So you're going to see deep S waves in V1, V2, tall R waves in V5 and V6. There are these Sokolov criteria. We just add them up. If it's greater than 35, then we know that's LVH. However, another great thing you can look at, if you see, like in this case, the overlapping of the complexes, that's a very good sign that that is a left ventricular hypertrophy. So I hope that answers your question about the hypertrophies. Again, you can look 13 plus 25 is greater than 35. And there's your thing. Same thing here. You have these overlaps. LVH. T-wave strain and inversions, last thing that you may see with a lot of these LVHs, where with prolonged hypertrophy from all the blood pressure changes, they get T-wave strain. So the T-wave, which normally should be the same direction as the QRS complexes, is flipped, and that's T-wave strain. Okay, Okay, so junctional escape rhythm. Okay, there is the junction. Junction is the AV node. Normally, the SA node fires and it tells the AV node what to do. Sometimes the SA node falters and it gets sick, sick sinus syndrome, and it's not going to work as much. So it stops sending signals to the AV node to do anything. The AV node has an intrinsic rate 40 to 60. So if there's a period of time where the SA node hasn't fired and then nothing is going on, eventually the AV node is going to send a signal to get the ventricles to beat, because it has its own intrinsic rate and it's waiting to be told what to do, but nothing is telling what to do because the SA node is out. So the AV node is just waiting there, waiting for a stimulus, nothing happens. Okay, I'm going to do it myself. But when the AV node fires by itself, let me change the color. When the AV node fires by itself, it sends a signal up and down at the same time. It's because the junctional is doing it. It spreads it from both areas and it spreads out. Because the atria haven't depolarized yet, they're still ready to go. So that's why when the AV node decides to fire, it can depolarize the atria. And of course, it's going to send the signals down to the ventricles and have the ventricles depolarize. That's going to happen. But when you have a junctional rhythm, it's coming from the AV node. But what you don't see are P waves. Why don't you see P waves? Because they're buried inside the QRS. Because it happens at the same time. They're both depolarizing at the same time. Ventricles have a much bigger mass. They're going to blend out or bleed, just get rid of the junctional, the P waves. So let me go to junctional rhythms now. Okay. Where's my junctional stuff? Okay. So, junctional rhythm again. No P waves because they're stuck inside. Very similar to why we don't see any atrial repolarization. We know it happens. We just can't measure it because the ventricles are going crazy and they're sucking up all the EKG paper. So you don't see them. So that's a junctional rhythm. Also, how do we know? Because the rate is going to be between 40 and 60. Why? Because it's the AV node that's doing all the work. So that's going to be your rate, 40 to 60. So there's 3 P wave possibilities. They're going to be absent, where you won't see them. They could also be inverted, where it'll be a negative complex. Instead of a positive one, it'll be a negative. Remember why? Because when you're starting in the junction, this is going to go antegrade to normal depolarization of the atria. And because we're going opposite, it's going to show a U pattern. If the SA node was firing normally and the impulse went this way to the AV node, then you have a positive P wave. So that's what the inverted one could be as well. Rarely, sometimes you can get a retrograde where the P wave kind of shows up here. That's a retrograde where it happens after the AV node, after the QRS complex. An accelerated junctional rhythm is still a junctional rhythm. There's still not going to be any P waves there. It's just that the rate is going to be greater than 60. But again, absent P wave or an inverted P wave or maybe a P wave that happens after that QRS complex. But that's going to be your accelerated junctional rhythms. Junctional tachycardia, same thing. And now you actually can see that P wave peeking in here after that QRS complex. So that is a junctional tachy. Again, it's a junctional rhythm. It's just got a heart rate above 100. This is not really positive. This is blended in the ST segment, and it's giving you the illusion of looking that way. But it won't be positive because it's coming from a different area. A premature junctional complex. Here's your normal beat. Normal. There's no P wave here. This is your junctional rhythm. Okay, no P wave. Also, if you were to march out the difference between these points, this should have fallen right here. That's where that beat should have been. But it's a premature because it came earlier than it's supposed to. Junctional, there's no P wave. I don't see it, but you see it in the other ones in a complex because it's there. So that's what a premature junctional complex can be. This is where the beat should have landed with normal cardiac cycles. But we had a premature beat. It ended earlier. Now we have what's called a compensatory pause. This is not a bad thing. This is called a compensatory pause. We're waiting for the cycle to start up again. So that's what you know, it's a compensatory pause, not a sinus pause, because you can march it out and it would make sense as far as where it should have dropped. So that is what that one's talking about. Here's your idioventricular rhythm. Idioventricular, again, why do we know it's ventricular? Look at that QRS complex. And this is the T wave there, but look how wide this QRS complex is. 1, 2, 3, 4, 5, 6 boxes wide. Okay. So that is obviously a wide QRS. It's got to be coming from the ventricles. Rate is very slow, less than 40. That is your normal intrinsic ventricular rate as well, or bundle of His. So that gives you that rhythm for that. Sinus exit block arrest, please. Do I even have it here? I'll see what they did. Okay. So in this case, sinus exit block. So what I mentioned before, let's start this, about marching it out. In this case, if we measured out the P's where they started, there should have been a P there, but it got blocked somehow. It didn't get out of the SA node. How do we know that? Because there's no P wave there. So this is a sinus exit block. Again, march out the P waves. They will always go according to the rhythm. Okay, 60 beats per minute is your heart rate. Every second, there's going to be a P wave. Now, we have a pause here. There's an absence. We don't have any cardiac cycle that should be there. This is a block because the P waves do march out. Okay. Same thing here. If you marched out with calipers, there should have been a beat there. That P wave never got out. It got blocked. Okay. Sinus pauses. SA node just stops firing. There's nothing coming out of that SA node. So because nothing's coming out of the SA node, it's not going to have a normal marched out pattern. You lose that because the SA node lost its rhythmicity. It's not going to fire the way it's supposed to. So it just pauses. There's nothing happening. SA node just stops. That's it. So we have to wait for the SA node to kind of wake up again. And then it starts doing its cycle and doing its thing, and your heart starts up again. Obviously, these patients are going to have bradycardia, lightheaded, dizziness, because they have these pauses. And the longer these pauses are without a beat happening, nothing's going on, then you need a pacemaker. Pauses usually will be longer than an exit block. However, an exit block means that you have sick sinus syndrome. That SA node is not doing very well, is becoming sick sinus. Eventually, those exit blocks will turn into a sinus pause because SA node is going to degrade, and eventually you'll have, just like how you have a second degree type 2. Second degree type 2 will degrade into a complete heart block. You just don't know when because you're randomly losing a QRS complex. So it's very similar to that. Eventually, you dropping random QRS complexes, you're going to go into a complete heart block. You're going to get a pacemaker. Sinus pause and exit block at first eventually will devolve into a sinus pause. So again, this range right there will not march out because the SA node just stops. It doesn't do anything. Okay. So arrest is the worst one. So it goes from block to pause to arrest. Okay, same patient, same rhythm strict. Again, that's that sick sinus syndrome. Okay. Go back to this one. Yeah, so you'll have a strip like this, and I'll say, what's the rhythm? That's the question. You have your answers. So obviously, looking at your intervals and dropping, but pure intervals. Okay, so basically, yeah, like this is a thing. This will be a type of question. This will be a question like, what rhythm is this? This is the type of strip that you'll get. And obviously, we know P waves are marching out the way they're supposed to. There's the P wave right there. They're fine. We have a third degree AV block. The AV node is dead. It's not going to conduct electricity from top to bottom. We get wide QRS complexes because the ventricles are causing the heart to beat. AVRT and WPW. So they are both re-entry arrhythmias. Okay, which means there has to be an accessory pathway, something allowing conduction to go from top to bottom. With WPW, it's just that in your ventricle, there is an accessory pathway that allows the conduction to get through. What happens, eventually you can get a circuit, and that is your re-entry rhythm. And the way you can tell that is because on the QRS complex, when it starts, here's your P wave, there is a slope to it. That slope is because this area is depolarizing faster than this area where the AV node is. This is going a lot faster. Why is it going faster? Because the AV node, remember, is a capacitance node. It's going to hold on to that charge for a second, allow the ventricles to fill. There is no regulatory body here. It's just a little piece of nerve that went from top to bottom and it goes. So you have this delta, the delta wave, and there's your WPW. AV NRT just has to do with the AV node. We have two pathways when the impulse comes down. We have a slow and we have a fast. When the impulse comes down, it's going to go down the slow, but it's going to take a long time. It's going to meander all the way through to get to this point. The fast side is going to go real fast, real through, fast, real fast, right through. Because it's so fast, when it gets through, it goes right down. By the time the slow pathway is ready to go, the fast one's already depolarized. It can't do anything. So the slow pathway just fizzles out. Nothing happens. However, if you have a premature atrial complex, some premature beat in the atria, and what that does is it makes the impulse come at a time that shouldn't be there. That's what a premature beat is. It's a premature electrical activity discharge that happens in the middle of a cycle. If it happens at the right time, this impulse will go this way just like it normally does, but because the fast pathway is now depolarized, this rhythm can now come back up. And it can use that fast pathway because now it's depolarized, it's ready to go. This beat should not have been there, but it showed up. So then you can get a reentry loop with these premature beats, and it starts cycling. And as it's cycling, sends a signal back up that way and a back down that way. So you get a beat of about 150. That's where their heart rate's going to be if they have AV NRT. It's usually about 150. That 150, you also see that a flutter. A flutter also has a heart rate of about 150 because your atrial rate is about 300. 2-to-1 conduction, there gives you your 150. So hopefully that answered with AV NRT and WPW. Remember, they're reentry tachycardias. Your WPW will have the delta wave, and let me pull up one of their AV NRTs. You don't need to know about hypothermia. Now, those special ones, Dr. Ovalle will be going over with you and reinforcing what you'll see with those changes with hypothermia. Let me go to an AV NRT here. I don't have it on mine. Let me go to his. Okay. So I mentioned before with AVNRT, because it's cycling on itself and the way the thing is spreading out, it almost looks like a junctional rhythm. And because of that, you see the P waves happening retrograde. They happen afterwards because we have a cycling rhythm going on. And so AV nodal reentry tachycardia, or AV reentry tachycardia, atrioventricular reentry tachycardia. They are the same thing essentially. We have a reentry rhythm that's causing a circuit to form where the AV node is just cycling on itself and sending signals up and sending signals down. That's why you have this retrograde P wave, because we have a AV nodal reentry tachycardia. Okay, so you can see, oops. We're okay here, we're okay, and then it starts. And when it starts, you notice the P waves go away. They look like these pseudo S waves, but it's kind of bleeding into the next one. So if you see a pattern like this, rate will be about 150 with retrograde P waves. Could be a cycle rhythm. Third degree blocks with always going to have a wide QRS, because remember now they could, depending on where, but the biggest thing to know is there's no more communication between the top and the bottom. So now the bundle of His has to depolarize by itself. So the bundle of His, okay, the bundle of His is right there. There's our AV node right there. Bundle of His then sends the signals out. If it's high enough, then it can follow the same pattern almost of a normal depolarization, and you can get a narrow QRS. If it starts down here, then you start getting the widened stuff. That the wider the QRS means the further down we're kind of going there. So third degrees are usually going to have a wide QRS because the impulse is generating from the ventricles. It's not following normal pathways from the SA node down. Hannah, Amani, I'll get to your question in a second, but Hannah, there will not, even if there is a combo, I will only ask for like a specific thing. What's the axis? What's the infarct? What vessels involved with the infarct that you see? So forth. Junctional tachy is going to be wide, Callie. The junctional. It's coming from the junction, not the AV node. AV NRT is still the AV node, so it still can follow normal pathways. Junctional tachy is not coming from the AV node. It's coming from a little bit lower. Okay, heart blocks. Got to come up here. Also, AV NRT is really going to be around 150. It's going to be fast. The junctional tachy will get fast, but not that fast. Over 100, but won't get 150. Okay, it's not here. Okay. First degree AV block. The only thing that you're going to have in a first degree AV block is a long PR interval. That is it. Everything else is going to be normal. The rate's going to be fine. Rhythm's going to be regular. It's just the PR interval is long. It starts here and ends there. Obviously, that's very, very wide. That's a first degree AV block. That is just a normal finding in athletes. They have it. That's it. Just prolonged PR interval. Second degree AV block. Now we have an issue with the AV node itself. There are two types that you have to know. The first one, type 1, Wenckebach. The key with this one is the PR interval will continuously get wider and wider and wider. and then you're going to lose a QRS complex because the AV node will not let the signal get through. So, PR interval. We're starting to lengthen. Now we're getting long. And eventually, we drop a beat. I'm sorry, yeah. Lengthen, and then we drop it. Now it kind of goes back to normal almost. And look at the next beat. It's already lengthening out again. Okay, so that is second degree AV block type 1. PR interval continuously increases, and then you drop an entire QRS complex. Now, in what you're thinking of, Amani, with the PR interval is long but consistent, that is a AV node second degree type 2. So in this one, normal, we have a drop, same, drop. But even when they are there, they're normal. PR intervals are constant, except when they start dropping. Yes, the PR interval is long and consistently long. The only issue is you have drop P waves. They don't no complex with that. Now, look at the QRS complexes here. They're still okay because the AV node is still sending the signals for those QRS complexes. This patient, over time, is going to go right to complete heart block, and then they need to get a pacemaker. Okay, because this is very unpredictable. We don't know when they're going to be dropping QRSs. They may just have a total block, and once you have a total block, then you have complete heart block, and there's nothing communicating. You need a pacemaker. Here's another one. I think it's the same picture. Okay. And here's your third degree AV block. P. You see how the P waves, every arrow I'm drawing here is regular. The SA node is still going to fire like it normally does, but AV node shot. And so now you have the intrinsic ventricular rate taking over. There. Okay, if we counted this out, 300, 150, 100, 75, 60, 50, 40, 30. Down between 30 and 20 beats per minute is your ventricular rate. This patient will be extremely fatigued and tired. They may even pass out. I remember the problem when people pass out, they hit their head, they do different things, and they cause a lot of problems. And so these are just other examples. No relationship between the P's and the Q's. Now, the next question, Muniba asked about benign early repole. The benign early repole, all they're saying with that normally there's a little bit of a delay. I'm sorry, it's this way. Let me redraw this. Okay, our PR interval is pretty good. Now, in early repole. Early repole, the T wave just gets moved over. It's nothing to worry about. It's benign in athletes. It happens a lot. You don't have to worry about it for the exam. Just know that it exists. That sometimes the T wave can creep in, and it blends in. And it kind of like starts to creep into that space, giving you the impression that it looks like ST elevation. But they're not exercising. They're a young, healthy person. They shouldn't be having any heart problems. And you'll see this in all the leads. early repole is going to be in most of your leads. So you'll see that across the board. In ST elevation, ischemia, all those things, it'll be in the contiguous territories for those leads. So make sure you also remember I think it's in this one. Know your territories. This is a good picture too. Looking at, here's your, if you're curious about those horizontal leads, this is, if you can visualize this, then it makes a little more sense. Here's V1, V2. What is it looking at? Right ventricle. Here's V5 and V6. So what are they looking at? Lateral, left ventricle. That's why whenever you see bundle branch blocks, if it's right, V1, V2, because it's looking directly at the right side of the heart. And the left side is always looking at the V5 and V6 is always looking at the left side of the heart. Again, here's another way of looking at it as well. Here's your septals, here's your anteriors, then finally your lateral and your lateral precordial leads. Again, looking at those things. This is the one, make sure you know this one too. Here's your inferiors. Okay, and then your laterals, septals, anterior, AVR we never worry about, but it's a great, AVR should always be a negative complex. Okay, always be negative. If it's not, the thing you can check, see if you mixed up your right and your left arms on your leads. When you guys do your lab in a couple weeks, I won't be there unfortunately, so I'm sorry about that. I won't be there for the EKG lab. But you guys are practicing on each other. If you mix up left arm and right arm and you flip them, AVR becomes positive. And that's how you know that they have that issue. Now, question about posterior MIs. So remember, it's all looking at reciprocal changes. So if you're seeing depression before, depression is a marker of ischemia. But let's say they come in, they got chest pain, they're not feeling good. You do an EKG, they got ST depressions in V1, V2, V3, more of the anterior leads, but they're depressed, but he's got positive troponins. So he's having a heart attack. So what you do, you take the lead off of V1 or V2 and you put it on the back, because now the back is, the camera is looking directly at the posterior side of the heart. And if you had a posterior MI, when you put V1 on the back, it turns into ST elevation, because it's the reciprocal changes is what you're actually seeing, not the real changes. So if you ever see depression in V1 through V4 in those areas, double check to see if they have a posterior MI. Madison, you do not need to know between orthodromic versus antidromic AVNRT. So don't worry about that, Madison. No, I can't be there, unfortunately. Dr. Ovalle will be there tomorrow morning for your to proctor your exam. I'll be there on Friday to proctor your cardio. Okay, what else we want to go through? Actually, I got a good meme I gotta show you guys. Let me find it. I think it's in this one. So stuff like this. Yeah, I can put all these out there. That's fine. What's the rhythm? That's a question that'll be on your exam. It's going to have a full 6-second strip, but it may say, what's the rate? It may say whatever. So there will be some patient scenarios. Yes, there will be some basic, simple, straightforward questions. Yes, but what I'm saying is like I can't give you a 1280 kg with like ST elevations everywhere and be like, what is it? Sometimes you have to have history. You have to know what's going on with the patient before when you do these interpretations. That's why I say don't go off what the EKG interpretation is going to tell you. When you guys do your EKG in a couple weeks, it's going to say weird things on there because you're looking at these strips. Where's one that I can say? These are just interpretations. Okay, what's the axis? This will be a question. What's the axis? That's all it is. You have all this crap on here, but the questions are telling you what's the axis. So 1 is positive, AVF is positive, we're good. Normal axis. More axis. Okay, what's going on here? Okay, we're good here. Oh, let me put this in. We're good. And then we go into VTAC. So this is what you can actually see when someone's going into VTAC. They'll be fine, then all of a sudden, they're going into VTAC. And then this can devolve into VFib if you don't treat it and so forth. What was this question? Okay, what was your interpretation of this one? Okay, rate. Let's look at the rate first. Let me find one that's on the line. Here we go. 300, 150, 100, 75 to 60. So we know the rate is normal. Rate is good. Let's go to the next one. Rhythm. Let's look at all of our P waves. Looks good, looks good, looks good, looks good, looks good. Okay, P waves are the same going through. Okay, let's look at the PR interval. PR interval. Okay. Here's your one big box. You don't got to go anymore. Once you see one big box in one of them, you're done. They don't check anything else. So PR interval is good. Is there a P wave before every QRS complex? And for that, we want to look at the rhythm strip at the bottom. There's always going to be a rhythm strip at the bottom, which is a continuous strip going across the entire thing. In most cases, it's going to be lead 2. Sometimes it could be V1, depending on what setup you have. So we say have a PQRS, PQRS, PQRS. We're good there. We're sinus rhythm because there's a P before every QRS. Now, axis, rate, rhythm. We're in normal sinus rhythm. A, axis, the Rahi method. I know it's the cheer method, right? So the A, axis. AV lead 1 is positive. Lead AVF is positive, so we know we have normal axis. So we have normal sinus rhythm, normal axis. Now, the next one, rate, rhythm, axis, hypertrophy. Let's get to hypertrophy now. Let's look at the P waves. Do we see any P wave problems dealing with anything doing hypertrophy? No, those P waves are good. Okay, those P waves are normal. They're not peaked. There's no M shape there. So we don't have to worry about any atrial hypertrophy. Now, let's look at the other ones. This jumps out. That jumps out. I hope that jumps out at you. These deep S waves in V1, V2, V3. Deep S waves because of all the electricity being pulled away from that lead. Remember, every time you're looking at an EKG, it's looking at a camera that's looking at a specific part of the heart. If the impulse is coming towards the camera, you get a positive deflection. If the impulse is going away from the camera, from the lead, you get a negative deflection. In this case, there's so much electricity going to the left side of the heart that V1 and V2 is looking at all this impulse going far away. That's why you get these very, very deep S waves in 1, 2, and 3. Now, V5 and V6, that's the left side. That is where the left ventricular hypertrophy is. We see a massive, R waves because of all the extra voltage going on. Now let's look at the T waves. What do we see with the T wave? We see a flipped T wave. T wave strain. You see that a lot with left ventricular hypertrophy. This EKG, if someone came in to see you and you wanted to know, do they have any high blood pressure for many, many years, and you did this EKG, it's going to confirm, yes, this patient has left ventricular hypertrophy from long-term high blood pressure. This is why where EKG comes into play. It's confirming your diagnosis. And that's all these imaging and these diagnostic tests are for. They're just going to confirm what you think is going on. Rule in things, rule out. If they're having chest pain, get an EKG. EKG looks like this. If I came in with chest pain and this was my EKG, would you guys be worried? No, there's no ischemia. There's no signs of elevation, ST elevation. There's no signs of ST depression. So normal EKG, and this answer would be like, these are your choices. That's your answer. Normal sinus rhythm with left ventricular hypertrophy and T wave strain. Yes, Nathan, that with the left bottom branch block with the MI, that's a very complicated EKG, and that will not be on your test. That won't be. They're all going to be very straightforward as far as the EKG. Now, technically, normal sinus rhythm is correct, but you would have missed the hypertrophy if you didn't follow rate, rhythm, axis, hypertrophy, and then injury, which is the last one, injury. And what are we looking at for injuries? ST elevation or depression? There are none. This is your pre-excitation, actually. Well, it's not benign at this point because we know they have the LV strain. But if you just saw this in a normal person without LVH, could be that benign early repole because this T wave is very, very close to that QRS complex. Okay, so in the slide it says cause for right axis deviation is LVH. Okay. Let me go to my stuff. Well, look at what they say. There we are. Okay. I'm trying to think why that does it, because then it's going to have the opposite with the right. Hang on one second. I'm just trying to figure this out. Yeah, they're wrong. This is the right one. Left axis is from hypertrophy. So Madison, you guys are right. Left axis deviation, left ventricular hypertrophy, because if you think about the heart and how it sits, and we put our circle around it. If you have LVH, change the colors here. The heart gets bigger and it shifts. So you will get a left axis deviation with LVH. The right ventricular hypertrophy that shifts to the right, and the right picks up a lot more of the, it probably could be one of them. I will double check the exam to make sure that won't be a confusion. Right axis deviation, the heart is going to shift to the right. Also, lung disease for right axis deviation. Thin hearts. People who are very, very thin, the heart moves and it shifts more of a straight downward orientation because people are very, 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 very thin and frail. Heart shifts and it makes it go to the right. So thin people, lung diseases also shifts to the right. So the big things are, if it's a right axis deviation, RVH, your pulmonary diseases, anything affecting the right ventricle can cause a right axis deviation. These are just depending on where they're causing issues. Again, normal in them. This is your northwest axis, extreme right axis deviation. Lead transposition, that's when you mix up what's right arm and left arm. You flip them. VTAC can do it. Atrial pacing. Anyone who has a paced rhythm, it's very hard to figure out axis because they're going to be in an artificial way that they're being stimulated. The leads, the way they go in the heart, they don't follow the normal progression so much, so you can get some off, some axes that are off there. So I hope that clears up with regards to right axis deviation. And so that you said 235 was that one? On their slides? Okay, let me see. Yeah, I was there before, but yeah. This goes over there. That should be right ventricular hypertrophy, not left. Okay, you guys showed up. I'll give you a hint. Just know the right axis deviation one. What are the causes of right axis deviation? Know your basic stuff. Know all the intervals. Know what all the paper does. No interpretation. You'll have just straightforward. Half of it's images. The other half are just questions. Yeah, so no right axis deviation. No, like what's considered tacky, what's considered Brady, what are the rates for that? And remember, all of the answers are going to be on the paper in front of you in the answers. If you don't know actually like what rhythm it is, if you see something that says ventricular something, no, it's got to be, yeah, I'll pull it up. Look at the answers. If it says something about tachycardia, you know the heart rate's got to be above 100. If it's not above 100, it can't be a tachycardic rhythm. Just think through these questions. Even if you don't know the answer has to be there. It has to be one of those four things. Let me just find a... special test. Actually, this is a good video too. I'll play this right now. You can't even hear it. Oh, let me do this. Well, anyway, I'll make the link later. Okay. Here is a 12-lead EKG. One of the things to notice about these bundle branch blocks, they have to have a wide QRS complex. They have to. They have to be wide because it's coming. You have a interventricular, the bundle branch block, conduction delay. Something is blocking the conduction, whether it's the left or the right, there's still a conduction problem. You're going to have a wide QRS. Now, V1, V2, we have these deep S waves. Okay? Because of this, and this, you can see a little bit there, that is the bunny ears. And that, because it's dealing with 5 and 6, that is your left bundle branch block. Here's your scarbosus, here's your right bundle. Here's your right bundle. Now we really do get that really good bunny ear pattern. But where do we see it? V1 and V2. If you see it V1, V2, it's got to be the right side, right bundle branch block. Just like ventricular hypertrophies. If it's on the V1, V2, it's the right side of the heart. So on and so forth. So know where they are looking at the heart, but also what side, left and right side of the heart. So these images, when you see that RSR pattern, the little bunny ears, in V1, V2, it's a right bundle branch block. That's the only place it can be. Don't worry about that strip at all. It was a very hard one. I kind of threw it in there, but again, I didn't teach you guys EKG, but I kept the quizzes, but don't worry about that strip. So Yadi, I hope that answers that question. Here's another one. Again, there's your RSR pattern in V1, V2. Okay, here's another one. A little bit creeping down there. But also, there's also STEMI going on. So again, right bundle with STEMI. That's why I don't want to include anything else. Here's your interventricular conduction delays. Again, just wide QRS complex. So it's going to be wider than 2 to 3 small boxes. Okay, so if you measured, it's a little bit bigger. That's all. So I hope that answered your question about this bundles. I'm going to go on Canvas right now, and I will post these lectures for you guys. You guys will be fine. Just, it's all pattern recognition. Just for right now, don't worry about treatments. There's nothing else. Just know pattern recognition. If you see things on V1, V2, it's anterior or septal, but also it could be the right side of the heart. V5 and V6 is the lateral, but it's also the left side of the heart. V3 and 4 are right on top. That's your anterior. 5 and 6 are your laterals, and so on and so forth. Know your rate recognition. Just go through your logical progression. Rate, rhythm, axis hypertrophy, injury. Okay, guys? Good luck. I'll see you guys. I'll be in tomorrow, so I'll see you guys after the exam. That's it. Good luck tomorrow. You guys will be fine.